Welcome to Mayo Clinic Q&A. I'm Dr. Sanj Kakar. Due to the COVID-19 pandemic, hospitals and clinics were forced to postpone non-essential appointments and surgeries in March and April. With newer, lower projections on the COVID-19 peak, Mayo Clinic is now prepared to not only meet the projected needs of COVID-19 patients, but to safely treat patients whose care was delayed and also to welcome new patients back as well. Joining us to discuss this is Chair of Mayo Clinic's outpatient practice, Dr. Conor Loftus. Dr. Loftus, welcome to the program.
Morning, Sanj. Thank you so much for the invitation to be on the show this morning.
So, Dr. Loftus, before we talk about the future, let's go back to March. Tell us what happened then, given how important and how busy the outpatient practice is to our patients. Tell us what happened back then.
So, firstly, I just wanted to thank you for the invitation to join this morning in the call. It's very, very important for our patients to know that we at Mayo Clinic are here and available to see them and provide the care that they need. And all of our staff members are here and available and have responded with optimal safety to ensure that we're able to deliver the care their patients need at Mayo Clinic. It's been a tumultuous 2 months for everybody, and those who are listening, I want to respect and appreciate everything that everybody has been going through for the last 2 months. It's really been a difficult time. But in times of difficulty, we pull together, we're strong, and we come out of these events stronger. If we roll back to, I'm from Ireland originally, and I think of the week of St. Patrick's Day. It was right around that time. St. Patrick's Day was on a Tuesday. That Monday was March 16. And that was a week of real change. We had a very, very active environment at the clinic that weekend. And at the time, if you recall, the external environment particularly was very unpredictable. There was the coronavirus situation was evolving rapidly across the country. We were beginning to see activity here in our own environment at Mayo Clinic. And we were scared, frankly. We were scared and we didn't know what to do because this was an unforeseen event. That's not to say that we weren't prepared. We had prepared for events like this, but the gravity and the extent and the rapidity with which things were evolving were such that for the safety of our patients, we felt it was really in the best interest of our patients, care team members, and staff members alike that we really reduced the scale of our practice massively and effectively overnight to protect the safety of our patients and care team members. So it was really driven by the external environment. The predictions at that time were such that we were going to see a tsunami of coronavirus activity within our working environment. So we needed to adopt rapidly to be ready for that, particularly in our hospital environment with ICU beds, but also in the outpatient practice. So it was the unpredictability of the external environment and what was potentially coming that really forced us, for safety reasons, to really reduce the practice to its bare bones effectively.
So you mentioned safety, obviously, for our patients and for our staff. As we're bouncing back, can you tell us the key fabric at Mayo Clinic is our staff? How have they responded?
I want to quote Charlie Mayo here, and this has become a favorite quote of mine as we've worked through this. And Charlie Mayo said back in 1920 or 1930, he said, one of our greatest strengths is our ability to translate idealism into action. And boy, have we seen action over the past 6 or 8 weeks. And we've seen action across the spectrum. From the standpoint of our staff members, our employees, staff members, it's been unbelievable what everybody has been willing to do. Number one, everybody respected our call for action that we needed to scale down the practice for safety reasons, for the safety of our staff, for the safety of our care team members, for the safety of our patients, of course. So we had to shut down our practice. That was tough for people. We go into medicine to care for our patients. Our patients need us. Our staff wanted to be here to see the patients. But they were able to pivot. They were able to transition quickly. And the urgent patients that needed to be seen, we continue to see them here on campus. And the patients that did not need to be here on campus, we continue to reach out. Those who were scheduled, some of them we deferred, and we're rescheduling now. And those who still needed ongoing care, we cared for them through multiple telemedicine modalities. So from our staff and employee and provider and care team members, they all responded rapidly. They got established with telemedicine at home, with cameras, with telephonic abilities to remain connected with our patients. And so we were able to thankfully continue to care for our patients by other modalities. From the standpoint of those, we have tremendous teams of people who continued to work at Mayo to see the urgent patients on campus, and many providers were seeing patients at home. But then there were a number of teams working on multiple mitigation strategies that I'll perhaps speak about here shortly in terms of working to prepare the practice to reopen at some point. We had just a tremendous pulling together and union of forces, and other Mayo Brothers euphemism in terms of just the strength of our staff at a time of difficulty was really impressive. The staff who were continue to see our patients, and the staff who were here preparing the practice to get back on its feet.
Amen to that in terms of how the staff have worked diligently through this. You just alluded to the mitigation teams. Can you talk to us a little bit about that and what you've seen happen over the last several weeks?
Really, it's been a period of preparation to reopen the practice. So if I roll back again that week of March 16, we were putting our practice on hold before the executive order. So the executive order actually went into place on the night of Friday, March 27. So it was about 10 or 11 days later, not because of Mayo, but we all saw that coming. And so we were communicating out to our patients ahead of time, putting the brakes on the practice. And from there on, really at the very beginning, it was caring for the patients who needed to see us during that time. We had many patients coming in with serious and complex disorders who needed to be here, and we needed to care for those patients in a safe manner. And so we were able to care for them in a safe manner. But then we had to think about many patients were deferred. And deferred, we had patients here waiting in town with cancers that they wanted their cancer resected, with serious disorders, and they needed that care. They were sitting here oftentimes in town waiting for the care. So our surgeons really led the charge in terms of reopening the practice. And they said, boy, we need to get these patients into our operating rooms. We need to get the patients taken care of. So a wave of planning went into place in about the 10 days or 2 weeks leading up to the week of April 6, particularly for our surgical patients. And we were able to begin to reopen the surgical practice with our surgical practice leadership on Monday, April 6. So the surgeons, and this was for urgent operations that needed to take place. Elective surgical procedures, of course, were under the executive order, and there was no elective surgery. But urgent surgeries, particularly for patients with cancer and other serious and complex illness, began that week of April 6 and has been moving forward since then. So thankfully, we've been able to reach out and care for many patients with cancer and other serious disorders from the surgical standpoint. Following upon the surgical lead, we put plans in place to open the outpatient practice. Again, many patients have been deferred. They can't be deferred indefinitely. Those patients who were deemed semi-urgent were becoming urgent. And so, and I can speak about it in a moment, we put multiple safety measures in place to ensure that we were able to bring back our outpatients as well. So beginning on Wednesday, April 15, we started to reach out to our patients. We said that we have multiple safety measures put in place. Our practice is safe. The patients who have been seen for the past number of weeks have been safe. Our surgical practice has reopened and has been safe. And now we're ready to reopen our outpatient practice. So we've been scheduling beginning April 15 for all of our outpatients. And thankfully, our patients need our care. They're willing to come back. They are coming back. Our outpatient practice is back at 60 to 70% of its face-to-face volume currently, and moving forward very safely and successfully, thankfully.
So when you talk about the outpatient practice, obviously there's many moving parts. You know, we talk about patients coming into Mayo Clinic safely, being seen by their providers in clinic. moving seamlessly through the flow of Mayo Clinic, and then, if it deems necessary, having surgery. Can you talk to us a little bit about the safety measures that you've implemented for this to happen?
Tremendous work has been put in by many teams to ensure that we have optimized our safety for patients. And it really begins at the very beginning of the patient journey. When we call the patient to schedule an appointment, we firstly have a screening mechanism when we call. We don't want to be overly invasive, but we want to ensure that the patient is safe to travel. We want to ensure that our environment safety is optimized and our care teams are safe as well. So we have a questionnaire, a screening questionnaire where we ask questions with regards to the symptoms that may be related to coronavirus. We ask if there were any exposures or household contacts, and a series of questions takes place on the telephone as the appointment is being made. We also educate our patients at that time with regard to some of the changes that they can expect when they come to Mayo, particularly with respect to universal masking. So we do ask that all patients are masked, and we ask that all visitors are masked on the campus, and all of our employees are, of course, masked as well. And that has been a tremendous benefit in terms of reducing risk. We also inform our patients and visitors that, unfortunately, at this time, we can't allow a lot of visitors on campus. In the outpatient practice, we allow one visitor with a patient, and in the hospital environment, there are no visitors with the patients. There are exceptions, a small number of exceptions that have to be signed off upon on a case-by-case basis. So that first telephone call is the initial level of screening. Before the patient arrives, we again reach out to the patient 48 hours before their appointed time, because you can imagine there may be 3 or 4 or more weeks between the time of the appointment and the time the patient is physically due to be here, and things can change. So we reach out to the patient 48 hours before they're arriving. We again screen them thoroughly with the same questionnaire as at the time of appointment. We actually then proceed, if they have passed that questionnaire for the second time, we proceed with a virtual check-in process. So we actually go through their medications, we go through their check-in virtually at 48 hours prior to appointment, such that when they arrive, their movement through the clinic is more efficient and less face-to-face contact with our check-in process physically and with our staff members when the patient is here. So once they've gone through the 48-hour check, then they arrive on campus. And we have additional screening as the patient arrives on campus. I just walked by our Gonda lobby front door, and it was quite busy down there. We've got screening with multiple staff members and nursing staff right there, where we ask the questions again. We actually measure the patient's temperatures and visitors' temperatures as they're arriving on campus. That's not with a thermometer, that's with an infrared screening device. We effectively just screen your forehead and we can tell your temperature very quickly. And then for the fourth level of screening, we actually question the patient again as they arrive at our desks at Mayo Clinic to ensure that, again, that there are no symptoms that are going to compromise safety. So you can see it's very, very, very thorough, and thankfully has been very effective. And I would pay tremendous credit to our patients who have been so patient through all of this, and they understand and they're willing to go along with all of this to ensure that they and our staff members remain safe. So the screening mechanisms are extremely thorough, number one. Number two, universal masking. That has been huge. All patients, all visitors, all employees masked. That's a huge change, but also very, very, very important in terms of efficacy. And then the two other big spaces, one is management of our patients and facilities. As our patients are on campus, we ensure that social distancing is maintained. We ensure that we don't have crowds of patients in waiting areas or in phlebotomy areas or anyplace else. We have colleagues from various teams helping our patients to ensure that they remain masked, that they remain socially distanced, offering hand sanitizers. And if we're observing patients as they go through the process as well. If we observe any patient that's coughing or maybe symptomatic, we actually ask them to step aside and we put them through an additional, more thorough screening mechanism as well. So multiple steps. And the final step is patients who are coming in for surgery. or for higher risk procedures. So if a patient is going to surgery, they're tested with a nasopharyngeal swab 2 days before surgery to ensure that they don't have coronavirus. Likewise, patients who are going through a number of different procedures are tested ahead of time to ensure that they don't have coronavirus, because it's very important that those patients are managed in an appropriate way. So multiple steps to enhance safety of patients and care team members alike. And thankfully, this has been quite successful, and our environment has been safe, and our patients are moving through quite well currently.
No, absolutely, and it's extremely thorough. And even as a provider, I've noticed myself is social distancing, and even in the elevator, of where you can stand in the waiting rooms, people are spread out nicely. And as you said, the check-in process when you come through into the clinic and actually see the provider, it's staggered in a way to maintain that social distance and keep safety first and foremost in mind. Can you talk to us a little bit when the actual patient then sees the provider? What are the safety measures that have been implemented there? You talked about everybody being masked, which is obviously key. What else have you noticed?
So we see our patients normally in the normal office. We do try to minimize the movement of staff members around the patient. We want to optimize our care, but as I indicated previously, we have a 48-hour ahead of time check-in. So there's less face-to-face time with our check-in staff. Our check-in process is as it was before in terms of screening. So we ask the questions again at the desk. The rooming staff will then bring the patient to the room. What is different now is that in our rooms, the patients who are familiar with our rooms, we maintain social distancing within the room. The provider is masked. The patient is seated at 6 feet from the provider, so a little bit further down the bench as opposed to at the near end of the bench to the provider. And if the visitor may attend in the room if they wish. If the visitor is in attendance in the room, the visitor is not seated on the couch. The visitor is seated off to the side on a separate seat or in the corner, such that we maintain social distancing in the room. The interaction itself, we always maximize our hygiene measures with hand washing, and patients may notice providers and others hand washing even more. Hand sanitizers are being offered, but the actual patient interaction is as it has always been at Mayo Clinic. We want to spend time with our patients. We want to ensure that they get the best care possible. We want to listen to our patients. We want to examine our patients, and all of these measures take place as they always do. The patient is masked in the room, the provider is masked in the room, and any other care team member that comes through is masked in the room as well. But all of the interaction itself is as it always has been. And then when we leave the office, as we always do, we walk the patient back to the desk, and we communicate with our care team members, and the patient proceeds through their itinerary as they always have done. And this is our multidisciplinary practice is operating as it always has. We have access to all of the services that we need. Our surgical colleagues, our procedural colleagues, all of our specialists are available. All of our various services and care team members are available to ensure that the patient who comes to Mayo Clinic gets the best care possible.
No, and I think our patients recognize that. Only this week, when I've been seeing patients, they truly feel safe coming back to see us, having their problems dealt with in the way that we traditionally do at Mayo Clinic. So thank you for that. This is obviously face-to-face interactions, but as you alluded to earlier, when the executive order came down and before that, there was a shift to telemedicine. Do you think moving forward that telemedicine is still here to stay?
Telemedicine is a fantastic enhancement to our face-to-face practice. Telemedicine is definitely here to stay. We, of course, were working hard in telemedicine as all other institutions were before this. We have a tremendous team of connected care colleagues who were working in the telemedicine space. We had a plan for telemedicine to be heavily invested in our practice over many years. That plan was accelerated effectively overnight. Both telephone consultations and video consultations effectively exploded in those weeks where the executive order was in place. We wanted to remain in contact with our patients. We wanted to ensure our patients that we were here for them and safe for them if they needed to be here on campus physically. We wanted to be able to continue to deliver the care that they need and to ensure that their needs were taken care of during this period. Telemedicine has been tremendously valuable. I think about one patient where I delivered a video consult to a very, very grateful lady on an island off the coast of Maine. And this lady is living on an island off the coast of Maine. She unfortunately has a bowel obstruction due to a problem, and she's on nutrition by vein, and she's got a tube coming out of her stomach. So traveling to Mayo Clinic with all of these very difficult accessories and feeding would have been tremendously difficult for her. We were able to deliver into her home a video consult. I then connected with a surgical colleague who did the same. We decided that the patient does need to come to Mayo Clinic for surgery, and that patient is scheduled now for surgery here in forthcoming weeks without ever having to come to the campus. So this is really transformation within our practice, and it's an example. And I know thousands and thousands and thousands of telephone visits and video consults have been executed upon like that by many hundreds and thousands of our care team members and providers across the enterprise, across the practice, and we are extremely grateful for everybody doing so. Many patients have been touched in this manner, but we also have to think about what we have done for the past 150 years. Our face-to-face practice is absolutely second to none, and that face-to-face practice, where we bring a patient to Mayo Clinic, we have an itinerary which is very, very organized, very efficient, seeing multiple providers in a short period of time. That's been our mainstay. That's been an absolute differentiator. And I see telemedicine as enhancing that face-to-face practice in most cases, as opposed to replacing it. So we're now hardwiring in, for example, I'll give a couple of examples. Once we have patients scheduled to come, new patients at Mayo Clinic, I believe that we will use video consults or telephone consults up front in many cases to connect with the patient ahead of time. I'm Dr. Loftus, I'm Dr. Kakar. I'm going to be meeting you in a couple of weeks' time. I want to ensure that we have everything in place. That may be a provider reaching out, it may be a nurse reaching out, it may be another colleague reaching out to ensure that we have the itinerary as it should be and we're prepared for the patient such that they get best care at Mayo Clinic. Another example may be established patients. Dr. Kakar has operated on them and fixed their hands. Do they need to be back here at Mayo Clinic, or could that be potentially a virtual consultation as opposed to the patient traveling a long distance if they don't need additional surgery or a diagnostic test? But then many patients, and the vast majority of our patients, will still need to come to Mayo Clinic for that face-to-face multidisciplinary practice, for the surgery, for the procedure, for the advanced diagnostic testing that has always differentiated care at Mayo Clinic for centuries, for 150 years. So in summary, telemedicine is definitely here to say it's an enhancement, but I see it as enhancing the face-to-face practice as opposed to replacing the face-to-face practice.
Yeah, Dr. Loftus, I couldn't say that any better. But as you said, the word enhancement is absolutely there, and it's extending that human touch to somebody when you can't see them physically. It means so much to our patients, and I'm so glad that you expanded on that and how it's sort of enhancing our practice, both face-to-face and virtually.
I would just extend tremendous thanks across the board. Firstly, to you, Dr. Kakar, and to your colleagues for arranging this interview. It's extremely important that our patients know that we're here for them. We're always here for them in times of difficulty. We're here to be a guide and to be of help in any way we can. Mayo Clinic is safe. It's safe, and we're here to care for all patients' needs now. I also want to thank any staff members who are listening. Our staff have been absolutely unbelievable in their response across the board to ensure that we are able to continue in our mission in clinical practice, our mission in education, and our mission in research, to continue to advance medicine to care for all the patients who need us.
Our thanks to Chair of Mayo Clinic's outpatient practice at Mayo Clinic, Dr. Conor Loftus.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all the Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then, click on Podcasts. Thanks for listening and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.